Hello, welcome to our presentation on the unmatched clinical capabilities of Trinia. I am Vin Morgan, a general dentist and CEO of Bicon, along with Dr. Estevam Bonfante from the University of São Paulo in Bauru. We shall hopefully present you with meaningful material about not only the composition and physical properties of Trinia, but many examples of its clinical use, which should offer you and your patients many financial benefits. Trinia is a 10-year-old revolutionary material comprised of roughly 40% resin and 60% fiberglass. It's a CAD/CAM material. It is similar to the material that comprises over 50% of Boeing's 787 airplane. It will allow you to treat your patients in less time, fewer appointments, with greater flexibility, which all amounts to significant financial benefits to you and your family. For example, if you can treat a patient in only 2 clinical visits instead of 3, or only 2 visits instead of 4 appointments, you can eliminate either 33% or 50% of your potential failed appointments. A failed appointment is a very expensive event. Let's take a look at a video that will demonstrate to you a significant difference between zirconia and Trinia. Yes, with Trinia, you'll never have a catastrophic event. What a benefit to not only you, but to every dental technician. Think about it. You'll never have a catastrophic event. Combined with the 360-degree positioning of the Bicon abutment, Trinia can provide for you a whole new way of inserting prostheses. For example, the following video will demonstrate a revolutionary way of seating a 4-unit bridge. The impression for the prosthesis is nothing more than a round peg in a round hole. You put the impression post in, you slide the sleeve onto it, and then you take a conventional impression. The accuracy of the components and of Trinia itself and its framework provide you the opportunity of going directly to seating the finished prosthesis without a frame try-in. On the second visit, you loosely apply the abutments into the prosthesis. You transport the abutments to the mouth in the prosthesis. They orient and seat the abutment. Then you engage the abutment more definitively. You place Vaseline over the pontic area of the prosthesis to facilitate the removal of extraneous cement. And you cement the prosthesis with any resin cement. It's totally passive. And if it were not, you simply can use a finishing burr to adjust the internal bore of the prosthesis to make it passive, because it need not be a precise fit. Cementing with resin cement, which bonds to the Trinia and cements to the titanium post. The clinical capabilities of Trinia have placed us in a situation where we can no longer justify using implant-retained overdentures. Consider, a tissue-borne implant-retained overdenture is time-consuming and maintenance-intensive. If you were to put a pencil to the paper, you too would realize this. For a tissue-borne overdenture, the first thing you must do is record the mucobuccal fold in the impression. As opposed to, for an implant-borne prosthesis, you simply have to record a portion of the ridge and a portion of the impression post, significantly less time. Then, when it comes time to inserting the prosthesis, the implant retained tissue supported has the potential for many sore spots, whereas the Trinia prosthesis has no contact with the soft tissue, and therefore you do not have the potential for sore spots. I don't know about you, but I have often spent more time adjusting a denture than fabricating it. And yes, that's time and that is money. Then it comes to the maintenance of the 2 prostheses. The tissue-borne prosthesis must be relined in order to maintain the support of the soft tissue, whereas the Trinia implant prosthesis has no tissue contact and does not require the regular maintenance of being relined. This greater flexibility, apart from the scientific laboratory explanation of it, is simply understood by saying it's easily modified with a finishing burr. Says a lot. Very difficult to cut zirconia, very difficult to cut chrome cobalt. Then additionally, everything bonds readily and well to Trinia. Think about it. Chairside restorations as opposed to laboratory procedures. The two physical or mechanical properties that enhance the merits of Trinia are its modulus of elasticity and its flexural strength. As such, because of its flexural strength, you can have a canine positioned implant and provide your patient with a first molar occlusion. Trinia cannot, by definition, be a lever or a cantilever. But the definition of a lever and a cantilever requires a rigid structural object. Trinia is not rigid. To help you understand why we say the longer the distal extension, the better, possibly this graphic will help you. If you were to have a rigid bottle opener, the lever would facilitate the removal of the cap. However, if the bottle opener were flexible, it would not exert the necessary force to remove the cap as was done by the rigid object. And then the longer the bottle opener, you can see the less effective it would be to applying force to the bottle cap. So much for Ante's law. Clinically, you can see an example of Dr. Evers in Vienna. He had an implant that because of sensory dysfunction, he was unable to load the right implant. So the prosthesis has existed on only 3 implants for 5 years. And yet the most distal implant is the central incisor. So a central incisor positioned implant providing a first molar occlusion for his patient. This concludes our initial introduction to the Trinia. Now we will have Dr. Estevam Bonfante provide you with the science and his research projects associated with Trinia. Estevam, please.
Hello, it is a great honor to have you watching this webcast, and which is a great initiative by Bicon. So moving on to our topic, we believe there are 3 very important questions that you might want to have answered before you start seeing other clinical applications of Trinia. And these are, what is Trinia, or where does it belong among the classes of restorative materials that you're already familiar with? The second question, do we need Trinia, is here because we would like to present you some very recent evidence showing how the other all-ceramic materials, such as zirconia, how they perform clinically from very recent and reliable publication sources. And to answer the third question, which is what is Trinia's laboratory and clinical performance, we'll show you some research results that started from 10 years ago. So perhaps, hopefully, when you start using Trinia in your practice, you know what to expect. So what is Trinia anyway? Well, according to the latest American Dental Association definition of porcelain and ceramics, and this is public information, it's available at their website. They define porcelain and ceramic as a pressed, fired, polished, or milled materials containing predominantly inorganic compounds, including porcelains, glasses, and ceramics. So note that the word predominantly changes everything. It means that materials that are highly filled with glasses or with ceramics embedded in a polymer matrix and available for blocks or discs in CAD/CAM, they're now considered, since 2013 by the ADA, as porcelain and ceramics. So with that in mind, we have proposed a new classification system for all ceramic and ceramic-like restorative materials, where you see 2 families of materials that you're mostly familiar with, which are the polycrystalline and the glass matrix ceramics. And based on the ADA classification, we have proposed a classification of ceramic-like materials called the resin matrix ceramics, and that's where Trinia belongs, since it has 60% of glass fibers and 40% of resin. Now, there are 2 very important things to know in this slide, is that among the 3 materials that we see here, pretty much all of them, it's what we use in our practices, and all of them are available for CAD/CAM. But 2 families exclusively made for CAD/CAM, which are the polycrystalline and the resin matrix ceramics. And the second important thing to know here is that you can combine families in order to make aesthetic restoration. For example, you can combine a polycrystalline zirconia framework to a porcelain, which belongs to the first family of glass matrix ceramics. But Trinia is such a universal system that you can actually combine them with any material of these 3 families, or to most of them. Let's say you're a lithium disilicate user and you want to make a full arch restoration, and well, you can bond the lithium disilicate crowns to Trinia. The same with feldspathic porcelain. And even if you're a zirconia fan, you can bond a monolithic zirconia or a veneered zirconia to a Trinia framework. But as you shall see today, we believe that the most rational use of Trinia is with materials that belong to the same family of resin matrix ceramics, such as Chauffoid C blocks, Cerasmart from GC, and some others that we will show you today. So I believe that some of you may be wondering why glass fiber reinforced composite was chosen as a material for Trinia. And the reason is pretty simple. It's because of its lightweight. It is somehow straightforward to mill, because of its flexibility and yet very strong mechanical properties, and especially the ability to be repaired. Also, if you look around, fiber reinforced composites are in many engineering and biomedical applications, such as to replace tendons, ligaments, intervertebral discs, which only proves its very high biocompatibility. And I wanted to take a closer look at the Boeing 787, the Dreamliner case, because this was a game-changing in aviation industry. For the first time, a plane was now comprised of 50% of advanced composites, including fiber reinforced composites. A big part of it is on the wings, on the mainframe and the cabin, and the bottom of the plane and the fuselage. And obviously, not only because the wings need some degree of flexing, it reduces the overall weight of the plane, so it will eventually take up less fuel. But most importantly, and the key reason for the Boeing 787 having so much composite in it and fiber reinforced composites is the ability to perform bonded composite repairs. So the airline companies, they are able to do this within just a few hours. So they can do very efficient repairs within hours instead of days or even weeks, which used to be the case with other materials made up for an airplane. And if you think of a financial aspect, it's a disaster to have a plane grounded for 1 day or a few days for maintenance. From a financial perspective, it's really not good. And so this strategy of having so much composite eventually reduced the overall maintenance costs and maximize airline revenues. So I want you to think of Trinia with the very much same rationale here. Trinia, if you design it properly, and you will see that there are some specific design parameters that Dr. Morgan will show you, but if you design them properly, the framework itself will rarely fail. But the composite that goes on top of it to veneer it, just like any other material, it may chip. But if it chips, you have the ability to repair it chairside very quickly, just like in the Boeing 787. And I know that this all makes up a very nice story, but the main question is, do we really need Trinia? And I'll put this question in a different way. Should we expect any technical complications with the other all-ceramic materials that are available for implant-supported reconstructions? I believe that you likely agree with me that if the other materials are behaving phenomenally well, then perhaps Trinia is just a very, very attractive additional alternative, which happens not to be the case. So I'll divide this answer in two sections. So we'll first talk about fixed partial dentures and then full arch. And these are the results from the latest European Academy of Osseointegration consensus that was published a couple of years ago, where they showed that for fixed partial dentures supported by implants, they have observed a 22 to 50% rate of porcelain fracture, that only within 5 years. So think of it, if you think back in your practice, almost half of your patients coming back for a repair or likely a replacement of a zirconia breach, that's really not profitable and not really good for your practice. And moving on to full arch reconstructions supported by implants on zirconia veneered, these fracture rates within 5 years reached almost 35%. So all these very high rates of failure within the porcelain veneer for zirconia reconstructions led the authors to eventually conclude that these are clinically unacceptable. So we obviously need new materials. And this is a very important and interesting publication that I highly recommend you to read because it compiles everything that has been published on zirconia fixed and full arch prosthesis of the best designed clinical studies. And if you really want to stay away from maintenance issues, as Dr. Morgan mentioned, literature has shown that overdentures have been associated with very high biological and mechanical complications. And these include the need to replace the retentive elements, need of constant relining sessions, repair of the resin portions, and even implant fractures. And if you look at this other study, which shows the use of the three very, very commonly used systems for overdenture retention, this study showed that all of them required maintenance of the retentive elements. That's only within 1 year. So overall, this doesn't seem to be very encouraging nor profitable for your practices. And the other aspect is that we all know that our mandible flexes. So the human mandible presents 3 different and simultaneous patterns of functional deformation. So while we open our mouths, while we do some protrusion, while we chew, and basically when you insert a cemented or screw-retained full arch zirconia or titanium or any metal reconstruction, you're basically doing a rigid splinting in the mandible. So you see the cortical bone has a modulus of elasticity of 18 gigapascals, whereas zirconia has a modulus of 200, which means it's 10 times more rigid. You know, this number, it's the modulus of elasticity, which shows how much the material can bend without suffering permanent deformation. And titanium is 5 times more rigid than the natural mandible, while Trinia has the same modulus of elasticity of cortical bone. The point is, we don't really know what's the impact of mandibular deformation on the long term, but we can definitely not exclude the fact that all the stresses and the strain that may be imposed in the bone implant interface and at the prosthetic components will not eventually cause some type of clinical complication in the future. So bottom line is, Trinia is compliant with bone deformation, mandibular deformation. And this video shows exactly the amount of deformation that Trinia can suffer. So see, there's a load being applied in a typical flexural strength testing. You see that Trinia is deforming. If I remove this load, Trinia will come back to its original shape. So this is what a modulus of elasticity measures. And if I keep pushing until the material yields, then I can apply some formula to the load, to the area, and eventually get the flexural strength properties of Trinia. But you probably were able to see the amount of flexing that it's able to carry. Now, before we show the clinical capabilities of Trinia, I would like to show you some of the research that has been carried out a few years ago regarding the use of Trinia for 3-unit fixed partial dentures and 5-unit. So in the past, we have compared Trinia veneered prosthesis with porcelain fused to metal, with porcelain fused to zirconia, and we even had a group of Trinia with a connector area of only 3 squared millimeters, which is a heresy. You can never apply that in the posterior region for any all ceramic material, including zirconia. You could use that in the anterior region, but not in the posterior area. And what we have observed in these studies that we published 5 and 10 years ago was that Trinia survival was equivalent to porcelain fused to metal, which is up to these days is understood as a gold standard material. And it was significantly higher than porcelain fused to zirconia. And what I really want you to keep in mind is that when Trinia prosthesis fails under very high loads, this is what you usually see. We don't observe, we have never actually observed a Trinia framework fracture that was properly designed, but the composite that chipped, it's a composite that can be roughened, you can apply some adhesive, and you can get it back to function right away with bonding composite chairside. Just like in the Boeing 787, Now, can you do a repair in a porcelain fused to zirconia? Well, yes, you can, but you have to sandblast intraorally. Then you have to apply hydrofluoric acid, which we all know it's toxic. And at the end, you end up having composite, a resin composite bonded to porcelain, which are materials of different optical properties. And you will always have an interface that will eventually stain with time. And has zirconia improved over time? It certainly has, but this is a very recent study that was published just a few weeks ago by Dr. Ryan and his team from Beirut Arab University. And again, they showed that Trinia survival was significantly higher than porcelain fused to zirconia. So there are still a lot of challenges for improvement. This is something that we are sure of. This is what makes Trinia a very interesting material. So moving on to Trinia as a 5-unit bridges, and this pretty much represents as a segmented full arch reconstruction. And we believe that the shape that you see, which is a Trinia prepped tooth-shaped framework design, it's really a state of the art because it reduces the amount of veneering material, it reduces time to fabricate a prosthesis, and it obviously reduces overall costs. What we were actually investigating was what would be the best way to use it as a material that would be manually veneered or just with CAD/CAM blocks cemented to Trinia. And as you see, these are the two configurations that we have tested. And actually, both of them worked very well. They both fractured under loads that were very, very high and way above a maximum bite force for humans. But we were really interested in the shofu blocks bonded to Trinia because it's time effective. You can mill the blocks and bond them to Trinia, as we will show subsequently. So we designed this study, and I'm showing this video so you'll see how the bonding protocol should be done. And for this study, we used 18 5-unit bridges. We milled a total of 90 crowns. And one very important thing to do, both on Trinia and on the surfaces of the composite blocks, of the shofu blocks, is to perform some sandblasting. So we do that with 50 micron aluminum oxide particles for 10 seconds. And that's a very, very important step because it will eventually increase the surface area for bonding, and it significantly improves the bond strength. So we always want to sandblast the surfaces prior to bonding. Then we clean the surfaces with ethanol. We do the try-in, which is usually a blessing if you use the correct milling strategies. And if everything has been digitally designed, you usually have no issues. We have been using Serra resin bond from Shofu as a bonding agent. So they come into two separate bottles, one with primer, the other one with a bonding agent. So you apply both of them into the cementation surfaces of Trinia and of the Shofu blocks. And you really have to apply a very, very thin layer, not to interfere with the seating of the crown. But basically you apply a thin layer of the primer, let the primer evaporate, give it 1 minute for solvent evaporation. Then you apply the bonding agent, also a thin layer, you photo cure it. And then you can choose any type of resin cement that you like. It should be dual cured or even self-cured. We don't recommend photo cured cements, obviously, because of the ability of the light to reach the surfaces. And at the end, you seat each and every one of the crowns, you remove excess cement, and then you perform a final photo cure for 20 seconds on each surface. And then you have your bridge ready to be cemented. And for this study, we wanted to see how the prosthesis, the 5-unit, behaved as a whole. So we delivered loads into the first bicuspid, into the second molar, and in the very center of the pontic, where we believed that the worst results would be observed, because that's where most of the bending and of the flexing would be. And then we statistically combined all the data to see how the system behaved. So when everything was combined, we have observed that the 3 occluding surfaces resulted in very, very high loads to failure during fatigue above 1200 newtons. And to our surprise, in the area where most flexing occurred, that's the point where Trinia was most resistant. So overall, the Trinia framework worked very, very well. And just like we have observed previously, all the failures were confined to the Schoeffel HC blocks, which means that we can still repair them. But remember, these with such high bite forces, we probably won't see such extended failures as you see here. But even if you do, you're able to repair chairside. So as a take-home message, remember, according to the latest EAO consensus, the current materials that are available, the all ceramic ones for implant supported short and long span prostheses, still fail to deliver the best performance. They're still clinically unacceptable. And Trinia's laboratory findings support clinical use, and clinical research that has been conducted over the past 10 years do support routine use. Just to give you one example, this prospective clinical study of Trinia used for full arch reconstructions supported by only 4 short implants showed a 94% prosthetic survival rate over 5 years. So please stay with us, and I'm sure you'll enjoy the clinical applications that Dr. Morgan will show you. So back to you, Vin.
Thank you, Estevam. Now to show you our 10 years of clinical applications, which should convince you to the merits of this revolutionary material. As I have spoken for years around the world, I've used the phrase, hearing is one thing, seeing is believing, and doing is knowing. So let us show you so that you can believe what you see. Trinia can be used on natural teeth as a coping. The merits are you'll have excellent aesthetics, and if you were to have an open margin, it's readily sealed chairside with a polyceramic material or with a resin cement, and you no longer will have metallic looking margins. You just won't. Additionally, for removable prosthetics, Trinia is an excellent framework. In designing it, you would use in the software or the clasp, you'd use the settings for gold clasp. The merits of a Trinia partial are not initially seen, but in the elderly patient who has a 4 or 5 unit porcelain bridge that fails all at one time, it's not an issue because you simply can bond 4 or 5, 6 units directly to the framework. You do not have to look for mechanical retention. Additionally, Trinia can be used as an obturator. Although most of you probably have never fabricated an obturator, it can be challenging because if it's a little too long, it'll irritate the soft palate. But that's simply adjusted with a finishing burr. Big difference between that and chrome cobalt. And if it's a little too shy, then you'll have water coming through the nostrils of your patient. But that's not a problem because a minimal amount can be added to the prosthesis, light cured, and removed. So the flexibility of being easily modified and readily bonded to enhance the fabrication of obturators. For temporization, the wings of a Maryland bridge, if you will, can be very beneficial, either bonded or mechanically locked to the adjacent teeth because they're very strong and very thin dimensions. Now, Trinia can be cement retained, as you can see on the Bicon abutments, or screw retained, as you can see on the zygomatic implants. So for Tom DeWitt in Belgium, a one-piece Trinia prosthesis was minimal chair time. Think about it. No issues about being passive or rocking, etc. It's a boon. It's a boon to all of us. Let's take a look at another 4-unit bridge done in 2 restorative visits, this time a mandibular prosthesis. And in order to facilitate the transporting of the abutments, place a little Vaseline into the prosthesis, and that'll prevent gravity from having the abutments fall out. They're loosely positioned and transported to the well of the implant, wiggled and jiggled and seated. Once they're initially engaged, remove the prosthesis and once again, apply Vaseline to the undersurface to facilitate the removal of extraneous cement. This concept of using the prosthesis or a seating jig to transport, orient, and seat the Bicon abutments will be seen throughout this presentation, and it will be particularly important on the full arch restorations, as you shall see. Two restorative visits. Think about it. No longer do we use the words cut, solder. They just have not been part of our dental jargon for 10 years. You too will enjoy this benefit. Another example of the merits of Trinia, even when implants are not parallel. Clearly, these implants are not parallel. However, the first restorative visit is simply placing 2 round pegs into 2 round holes. Couldn't be simpler. Of course, you have to wait the 4 minutes for the impression material to set. Once the model is fabricated, then scanned, the Trinia framework is milled, the polyceramic material ceramizes, handcrafted onto it. And now the prosthesis is going to initially orient the canine abutment. Once it is engaged, the prosthesis is removed and the distal abutment is inserted into it and transported to the 3rd molar implant. Yes, 2 clinical visits, minimal effort, minimal time, and clearly non-parallel implants. And once again, Vaseline is applied to facilitate the removal of extraneous cement. The following video will demonstrate the immediate placement of an implant and the impression for the prosthesis on the day the implant was placed. And on the second clinical visit, the final prosthesis was inserted. On the first visit, the fractured tooth and bridge was removed, as well as a 6-year-old IAC on the upper right. The implant was placed. An impression was taken of the immediately placed implant and the 6-year-old implant. After the impression, the implant was covered, the healing plug was cut, bone was grafted over it. Then IAC received a universal abutment and a temporary prosthesis was fabricated, which was mechanically locked to the left central. 3 months later, to the day, as a matter of fact, the newly placed implant was uncovered and the final prosthesis had been sitting on the shelf waiting to be inserted for 2.5 months. And it was initially tried in with the abutments, and then subsequently a seating jig was used to definitively tap the 2 abutments. Once the abutments were tapped into place, then the prosthesis was again tried in and adjusted where the extraction site had been, and finally cemented with a resin cement. So there you have it. Only 2 visits to place the implant and take a final impression on the first visit, and on the second visit, seat the final prosthesis. Hard to believe? Not really. And subsequently, the patient had the Trinia prosthesis placed on his upper left 2 years later. Now let's discuss the full arch prostheses with Trinia.
In order to achieve clinical success, certain techniques must be followed in the lab. This video provides an overview of those critical techniques. Use only 3 or 4 appropriately spaced implants to facilitate the fabrication of the prosthesis. 5 or more implants unnecessarily complicates the prosthesis. If possible, place 3 implants while there are still teeth present, and then extract them when the final prosthesis is being inserted.
The prosthesis can be cemented directly onto an abutment. It can also be retained with screws with fixed detachable abutments, or you can have telescopic restorations with custom cast copings. And finally, which is our preference, is to have a telescopic prosthesis with retentive copings, which is clearly the most cost-effective and the one that we prefer to use. Cement retained. It's nothing more than what you saw with the cementing of the 4-unit and 5-unit bridge previously. Red Vaseline on the pontic, resin cement. One caveat that you should be aware of is that for strength, you must maintain 2 millimeters of Trinia over an abutment. This is where the Trinia prosthesis gains its strength. So please remember that you must not reduce the occlusal thickness of Trinia. This was one of our first Trinia prostheses, and you can see we use Mandibular composite teeth for the anterior for aesthetics, onto which we lengthened the teeth chairside by adding polyceramic material to the Mandibular teeth. There's the aesthetics after 8 years in function. Screw retained prosthesis. As you will note, because of the positioning of the implants, this entire prosthesis is a distal extension. Think about it. The entire prosthesis is distal to the implant, and yet it works and has for some 7 or 8 years with a screw retention. Custom telescopic copings is a ubiquitous treatment in parts of Europe, not in the United States, but the coping is inherently retentive on the abutment. Yes, each coping is inherently retentive and resists displacement on each abutment. is fabricated by a wax patent with a little plastic insert which provides retention and can be exchanged. There's a white, yellow, and red, all having different degrees of retentiveness, but it's a laboratory intensive procedure and it is not our preference. However, because of the positioning of the implant, sometimes it is necessary for aesthetic reasons to use these custom copings. The following video will show you the use of these custom cast copings. The temporary abutments are removed. And that's what you're looking at, the soft tissue well. Guide pins are placed to indicate the trajectory and also to support a sulcus former, which prepares the sulcus of the implant so it will receive the appropriate 5mm universal abutment. After the wax try-in, the copings are seated on the abutment and then they're picked up, or rather cemented, the resin cement into the bores of the Trinia prosthesis. Note the distal extension of the prosthesis. That's it. It's a resin cement. The bores of the Trinia can be very passive. It does not have to be a precise fit. You can add to, if there's a void around the coping, you can add to it, remove the excess. But notice the distal extension. And there it is a few years later. Note the distal extension of 25mm. Seeing is believing. Our preference, as I mentioned, is the universal abutment retentive coping. It's used with the 5 series universal abutment of either a standard profile or a tall profile. It is not used with low profile. The coping is not retentive inherently on any one universal abutment. It gains its retention from being attached to another coping. So it's the divergence amongst the abutments that gives the retention to the retentive coping. The beauty of these copings is they can still provide retention even though the entire coronal portion of the coping has been removed. A couple of millimeters of the cervical coping ring will provide the necessary retention. An example, the abutments are readily removed from the implant analog with the simple cotton pliers. Vaseline is placed into the seating jig, so the abutment is placed in loosely and transported to the implants with the seating jig. The seating jig will definitively seat the abutments in the well of the implant. Then the seating jig is given an initial tap to engage the abutments and then removed. Then a definitive tapping of the abutment is applied directly. And once again, the cotton pliers facilitates the removal of the abutments from the implant analog. And once again, Vaseline applied to the seating jig, which facilitates the removal of the jig without displacing the recently seated abutment. Essentially the same technique you saw when we were using the prosthesis to orient and seat the abutment. The jig is initially tapped, and then the individual abutments definitively seated by tapping on them. And that's it. The jig is removed without removing the abutments. Then the prosthesis is tried to see whether it fits over the abutments. And if it does, then the coping's placed onto the abutments and the prosthesis is once again tried in. And if it fits, you may have to do nothing. Or you may have to just reduce the internal bore of the prosthesis and you cement it with a resin cement. Vaseline is placed into the retentive copings to facilitate their removal when they are attached to one another with the prosthesis. Remember, the prosthesis gains its retentiveness from the divergence amongst the abutments. The prosthesis is tried in over the copings, removed, and checked to see if there's any adjustment necessary. There'll be a little black mark inside the prosthesis. And if there is none that has to be adjusted, replace the Vaseline to facilitate the removal of the extraneous cement from the pontic areas. Inject your resin cement into the bore of the Trinia and cement the prosthesis. It's as simple as that. The following presentation, will demonstrate the fabrication and 2-year follow-up of 2 full-arch Trinia telescopic restoration. The impression is taken, the model is poured, recording of the vertical dimension of occlusion, the traditional recordings that we do for any denture patient. Gothic arch we find very helpful to record the proper centric relation. Then the laboratory fabricates the seating jigs to facilitate the removal of the abutment. Once again, we use a simple cotton pliers. The seating jig transports the abutments loosely to the implants. They're tapped in place. Then the prosthesis is tried onto the abutments if no adjustments are necessary. Then we apply Vaseline to the retentive copings, seat the retentive copings, and then try in the prosthesis again. If there's a little black mark, we'll do an adjustment of the bore of the Trinia with a finishing burr. Then we'll apply Vaseline to the pontic area, add resin cement to the bore, seat the prosthesis. There is finished prosthesis, the occlusion, the aesthetics. After 2 years, you can see there's staining, and it can be readily removed. That's after the cleaning. Note the occlusion is still balanced after 2 years in function, even with very thin shim stock. Soft tissues, quite happy after 2 years. Radiographically, at the 2-year follow-up, you can see on the radiograph that you have the Trinia framework, then you have milled anatomic teeth. If friction wears and you get rotation or you have loss of retentiveness, all you have to do is simply rotate an abutment. Just increase the divergence amongst the abutments and you will achieve a newly retentive prosthesis. It's as simple as that. Just a slight rotation. As you can see, the patient immediately knows it's more retentive. Yeah, I'm happy. Relining. This is also a very beneficial procedure for both you and the patient. You do not have to coordinate the patient's time, your time, and the laboratory's time. It's a chairside event. You simply clean the surface, prepare it with the bonding agents, and then use the polyceramic material. Polyceramic material comes in many changeable shades. Place Vaseline into the bores of the prosthesis to facilitate its removal, and then after kneading the polyceramic material to soften it, you apply it, and you can apply the entire prosthesis or just an inch. And unlike do a chairside reline with methyl methacrylate, which has a bad taste and you're under time pressure to achieve it, there is no pressure with this, and there's no bad taste. Use the spatula to facilitate the movement of the material. The more you spatulate, the less you'll have to polish. On your final addition of light curing, use the oxygen barrier and then mechanically polish it. That's it. No involvement of a laboratory technician coordinating and schedules are necessary. What a boon to you and your patients. Full arch reline, no bad taste, no time pressure, no coordination with the laboratory. Full arch prostheses on 2 and 3 implants. Well, initially we restored our full arch prostheses on 4. However, for a variety of reasons, we found out that 3 implants are perfectly sufficient in both the mandible and the maxilla. Yes, while some people discuss the all-on-4 technique, which they're now saying maybe all-on-5 or all-on-6, we're saying, to our surprise, all-on-3 instead of all-on-4. And we'll show you. Look at that span. Hard to believe, it's reality, however. There's the copings seated, 19 millimeter, 17 millimeter distal extensions on 3 implants. A 25-year-old implant retained overdenture was replaced with a Trinia prosthesis. The patient came back for his first visit after 25 years, at which point he had lost an implant, and we fabricated both an upper and lower Trinia prosthesis on 25-year-old implants. And it's the same technique as you've seen. Use the seating jig to transport the abutments to the wells of the implant. Once you tap them in, you put the copings on, you try the prosthesis onto the copings. If they fit, you use a resin cement to pick the copings up. You remove the resin cement, measure the 25 millimeter distal extension. Yes, canine positioned implants, first molar occlusions. And 25-year-old implants, 2 full arch Trinia prostheses. Another. It is incumbent upon you not to remove all of the patient's teeth. We kept these 4 broken down lower incisors because they provided for us landmarks, especially for the technician. Think about it. No need to worry about orthic arch restoration. The first visit after the consult, we placed the implants, and 3 months later, our first restorative visit began. We uncovered the implants, used the sulcus former to shape the sulcus of the implant, and then we recorded the impression with 2 blue 2.5 millimeter impression posts and 2 3 millimeter impression posts and the existing teeth. Patient went home. Impressions went to the laboratory. Laboratory chose the abutment, reduced the anterior teeth from the model, fabricated the appropriate seating jigs, and the final prosthesis. On our second visit, we removed the temporary abutments, extracted the 4 anterior teeth, used the seating jigs to apply the universal abutments. Then, when the abutments are in place, 3 retentive copings and 1 custom coping were applied. The prosthesis was fitted, and you can see needed to be adjusted. There was a black mark, so we adjusted it. Picked up the 4 copings. Then we had to reline the prosthesis because of the extraction site and the resorption. Another. First restorative visit, we took the impression. The patient had 3 existing integrated abutment crowns. The patient is in poor health, 90 some odd years of age, 3 hours from our practice, and in 2 visits, we're going to treat this woman. First visit, take the impression, send it, the bite and the impression to the laboratory. The laboratory chooses the abutment, has a wax up comparable to the existing teeth that she had. There are the abutments, the seating jig, laboratory fabricated plastic framework. It's easier for most technicians to see and touch the framework rather than just viewing it digitally. Once it was approved and modifications were made to the initial plastic framework, it was scanned and the final Trinia prosthesis was fabricated. And then anatomic teeth were milled out of millable polyceramic material. It's easier for a technician to fabricate or design rather, milled CAD/CAM teeth as if they were individual teeth on post than trying to mill a full arch on a simple bar. So there it is. And on the second restorative visit for this 90-year-old patient, we have the final prosthesis. We extract the remaining teeth, use a sulcus former on her existing implants, and just watch. As we said, hearing is one thing, seeing is believing, and doing is knowing. You shall see exactly what we do and have done for 10 years. Seating jig transports and orients the abutments and initially seats them. Then the tapping on the jig more definitively seats them. And then tapping directly on the abutments is the final seating of the abutment. So there's 2 abutments on the left. The jig is removed. That has been Vaseline. The facilitates removal. Then a definitive seating of the abutments. And now we'll go to the right side where there's only 1 abutment. And once again, a seating jig will transport it. Remember, this is the second visit for a 90-year-old woman who's in poor health and who lives some 3 hours from our dental office. The 3 abutments are now in place. And now it's a matter of trying the copings on and the prosthesis. Once again, Vaseline is applied to the coping so that when they're united in the prosthesis, it will facilitate their removal without removing the abutment. When we deliver a prosthesis to a patient, we also place Vaseline to facilitate the initial removing and inserting of the prosthesis. So the 3 retentive copings are in place. Now we'll try the framework, and then if it fits, then we will fill the bores of the Trinia with resin and cement it. In this particular case, we adjusted one of the bores where the Trinia framework was not fully passive. Vaseline is placed, as you've seen over and over, to facilitate the removal of extraneous cement. In this particular case, since the extraction site were significantly without bone, we had to reline the prosthesis on the same visit. And that is simply done by cleaning the pontic area using the bonding agent, and then polyceramic material is kneaded. And the more you knead it, the greater the handling capabilities, it becomes soft. And then the use of a spatula is highly recommended. The more you spatulate, the less you'll polish. And you're under absolutely no time pressure whatsoever. There's no bad taste, and you have no time pressure to get it right, if you will, as you can see. We use the rubber dam to facilitate the application of the relining polyceramic material, Ceramount. Spatula, as I just mentioned, the more you use it, the less polishing you'll have to do. The initial light curing is done, then it's removed, and the final light curing is done after the application of an oxygen barrier. And you try the prosthesis in. Once again, this is the second restorative visit. Think about it. It's meaningful. It's a benefit not only to this elderly woman, but also to you, all because of the clinical capabilities of Trinia. This will be still pictures of the retentive copings, the prosthesis, the relined prosthesis because of the extraction site discrepancy, the aesthetics, 2 visits, radiographic evidence. Another example on 3 Bicon shot implants. The patient had IMZ implants of some 40 years or 35 years ago, and the fractured screws necessitated the placement of 3 Bicon implants. In the first restorative visit, the implants were uncovered, impression, both were inserted, the impression was taken, the wax try-in of the teeth, vertical dimension was recorded, Gothic arch was also recorded. If you're unfamiliar with the Gothic arch technique, there are excellent videos on YouTube that can facilitate your understanding and learning. On 3 maxillary implants, the abutments have a 1.5 degree divergence. Seating jigs and verification jigs are fabricated. The verification jig confirms the fact that there's a path of insertion and withdrawal of the prosthesis, as well as a retentiveness of the final prosthesis, and it's only used in the laboratory. Then the digital milling, designing and milling of the Trinia framework. As we mentioned, we design it so that it appears as though it had individual crowns as opposed to a simple bar. The milled anatomic teeth that are cemented to the Trinia. Then the Trinia material aesthetically is enhanced by adding polyceramic material. And on the second restorative visit, the seating jigs are used to transport, orient, and initially engage the universal abutments into the well of the implants. Vaseline is applied to the copings to facilitate their removal once they're cemented in the same prosthesis. So it's the same technique over and over again. If there's a void, and the resin cement can be added after the removal of the prosthesis, the aesthetics. So there's a cement-retained prosthesis on the lower, a hernia prosthesis of a number of years, and then the retentive telescopic prosthesis on the upper with the milled anatomic teeth that you can see cemented. And in this particular case, because of the presence of Alzheimer's disease, the telescopic restorations were cemented with a temporary cement. Another example of the clinical flexibility of converting a 25-year-old overdenture. The one implant with bone loss was not in function, and as you can see, it has bone loss. The first restorative visit, you simply remove the brevis abutments. You take the free impression post, red because of a 2mm well. Take the impression, you pour the model, Gothic arch, recording. Then the silicone mask, which confirms the spacing for the abutments as well as for the teeth. The digital designing and milling of the Trinia, and then the cementing of the anatomic teeth onto the Trinia. This image depicts a verification jig on the bottom, seating jig in the middle, and the final prosthesis on the top. And on the second restorative visit, the same technique is the transportation, orientation, and seating of the abutments with the seating jig, and then the copings, removal of the seating jig, trying of the copings, Vaseline, the Trinia enhanced aesthetically with the polyceramic material. The bores of the Trinia are filled with the resin cement and the copings are picked up. This final video will clearly demonstrate the mechanical properties of Trinia. Once again, seeing is believing. Patient, after multiple bone graftings, she was advised that she could not have any implants. However, Stefano Corelli in Roma, he was successful in placing Bicon implants. He placed 4 on the maxilla, and he provided this patient with a Trinia full arch telescopic restoration on the upper and with an overdenture on the lower, 2 implants for an overdenture. At the 1-year appointment, she expressed great gratitude for all, but particularly for the Trinia telescopic restoration on the upper. And she said, if I could only have the same comfort on the lower as I had from the upper, I'd be overwhelmed. So Stefano placed additional implants on the lower and then converted the lower overdenture into a Trinia. Actually, he did not. Paulo Perpetuini he did. He took the overdenture and the impression. He chose the abutments, milled them with the divergence. Then he placed the copings, used the silicone mask to determine the room, fabricated a verification jig to confirm the path of insertion withdrawal, as well as the retentiveness of the copings. Here's the seating jig. It's light cured resin that is relined to have more accurate adaptation to the abutments. He indicates the path of insertion, which abutment should be used, which. Now, this is the interesting aspect of the clinical properties of Trinia. The bores of the Trinia were placed into the existing prosthesis. Just drill away, easily done. Then he puts a bonding agent, puts a silicone in, and it bonds, and he adapts it to the copings. So the existing overdenture was hollowed out to form the bores to fit into the copings, and then the distal extension of the tissue-borne overdenture were readily removed, as you can see. If this were metal, chrome cobalt, or zirconia, you could neither create a bore within the framework, nor could you remove the distal extension with such facility. And then the material is hand polished. Think about it. We told you that at the outset that Trinia is readily modified, and bonding to it with any number of materials is readily and well done. So seeing is believing. So it goes from the overdenture abutments, the preface abutments, the bores and the Trinia. There's visual evidence of why the patient is happier with the Trinia. Look at the size of the extension necessary for an overdenture relative to a implant retained telescopic restoration. Significantly less material. So at the outset, we told you that we no longer can justify recommending tissue-borne overdentures now that we have Trinia with the capability of distal extensions. Happy? I would say so. I thank you for your attention throughout this presentation, and hopefully we have demonstrated, as we said we would, that you can achieve treatments in less time, fewer clinical appointments, greater flexibility, and significant financial benefits for you and your family. So remember, if you can treat somebody in 2 visits instead of 3, or 2 visits instead of 4, you eliminate 50% of your potential failed appointments. And a failed appointment is a significantly expensive event. Thank you for your attention.